So hello everybody, I'm Ron Waxman from MedStar Washington Hospital Center. We are CRT Online. This is a special series for COVID-19. And today I'd like to focus on two representatives from Europe. One is Elaine Chieffo and the other one is Nicholas Mieghem from Rotterdam. So we have Italy and we have the Netherlands. And why don't we start with you, Dr. Chieffo? You just left us CRT. You told me that you asked to come back to the hospital and take care of those patients. So tell us, what did you have experience over the past 2 months, and how are you handling the situation now?
You know, Ron, that it was a particular really experience for me because I left Milan on Friday. I was in Washington at CRT, and all of a sudden on Saturday, I got a phone call from my hospital saying that we could not do the live cases for CRT. That was supposed to be on Tuesday, so I had to run back. And in 2 days, honestly, I saw a city completely changing. I mean, I left Milan on Friday, normal city. I mean, for the one of you that know Milano is the center of Italy, center of our country. It's the most productive city of all the country. And I was back and I found a completely different city, starting a progressive lockdown. So things completely changed. It was like a tsunami in our life. I mean, you have your normal life working, you have this city that is full of anything, and all of a sudden it was everybody locked down in the house, and we as doctors, as physicians, going to work in a lot of fear, having no clue what's going on, because after China, the first country was Italy. So we had the few information coming from China and honestly no clue what to expect, and anything completely changed. There was a not progressive, I think it was an immediate lockdown of elective procedure and a complete restructuring of all our system. So we went to be, I mean, the largest center for TAVI, from the largest center from PCI, and now we are one of the 3 hospitals in Milano doing primary PCI. So my normal practice now is primary PCI. No more TAVI, no more complex procedures or no mitral clip. I mean, it's STEMI and acute coronary syndrome. So completely restructuring of the network, restructuring of the hospital, of the emergency room, or internal hospital path, COVID one place and cardiovascular emergency somewhere else. And hopefully things are going better now, numbers are going down, but we are still in the same concept, a little bit less number. We are, at the beginning, we could not see, that was very interesting, STEMI. They start to come slowly, very late, lots of shock and mechanical complication because they were arriving late. And now it's starting to be a little bit better, I have to say.
When you came to Milan, I think that was February 27 or 26, I remember the day. Did you have enough PPE protection for the staff when you started to treat those patients? And were you deployed as an interventional cardiologist to take care of patients with COVID-19, or they said you just stay in the lab and do the primary PCI?
So we were lucky in my hospital because since the region decided that we were one of the 3 hospitals in Milano, I mean, you know, we are serving now 7 hospitals that were doing before primary PCI. So consider all this big city full of CalLab, only 3 hospitals now doing. So we didn't serve COVID-19 patients because we were cardiologists and interventional cardiologists completely devoted to cardiovascular emergency. So our cardiologists are taking care of the emergency department for cardiovascular emergency, and us as interventional cardiologists would just take care about primary PCI. Regarding the PPE, again, we are lucky. We are lucky because I work in a private university hospital, and our administrative were very wise, and we did have all PPE, I have to say. So in the CALAB, we never had any problem regarding protection. And by the way, we are treating any ST elevation MI in the absence of a prior test as if they are COVID-19 patients. So we use the same precaution to all patients with ST elevation MI, because we don't know when they arrive, since they come immediately to the CALAB, if they are positive or not. But I mean, this is my hospital, I mean, and my practice. There were other places maybe where things were different.
Thank you. We'll hold the thoughts about how you treat those patients, and we'll move to the Netherlands. Nicholas, it was a little bit later on that you learned in the Netherlands that you also been affected by this pandemic. Can you tell us when was it? How were you prepared, and what was your hospital was handling? How your hospital was handling the situation?
Well, I think it was a different story in the Netherlands if you compare it to Italy. I think Italy really was almost caught overnight, and that really was a tsunami. We could at least see the wave coming. And I think also, you know, the more northern mentality is a little bit different from the southern mentality. So it was very well orchestrated. There wasn't any panic. And then very methodological, they were escalating the resources. So I haven't seen any panic in the Netherlands so far. I must also admit we did not see the dramatic images even from San Raffaele that I saw over the internet, with all these patients in the wards and in the ICUs, and we haven't seen that kind of drama here, but we were progressively escalating the resources, and I think they did quite an impressive way. An impressive work, but I must admit that at this point in time, we were not in need of all the resources that we were foreseeing. So basically, we never ended up with water out to here. So we always could breathe, and that also resulted in a different approach to our interventional cardiology practice. Of course, we reduced some of our cases, predominantly elective stable PCIs, stable coronary artery disease. Those patients were postponed, and also structural heart interventions that would require additional resources like general anesthesia or expected ICU care. Those cases were postponed. But for instance, our TAVI program just continued. So the only restriction or reduction in our program we experienced in terms of TAVI was the fact that referring hospitals were doing less clinic. So there were less referrals. So I think in general, I think our overall volume decreased with 10%. That's it.
And for primary PCI, because I've seen a very interesting graph from the UK that when we came to March 3rd, the graph which was like that with ACS, all of them dropped very dramatically.
Yeah, and this is, I think, the legacy or the result or the consequence of the political and public opinion. So everybody was talking about COVID-19 and they were neglecting everyday reality, and acute coronary syndromes are part of everyday life. And patients were still experiencing chest pain, but they didn't want to be a burden, so they stayed home. So that is what we did see. We did see more late presentations. We had a couple of LV perforations, ventricular ruptures, those kind of stuff we have seen in the last couple of weeks. And that is like a rarity. Normally, you would see it once on a blue moon. Now we had several of those cases. And that is, of course, because patients were coming too late to the hospital, unfortunately.
So, with your hospital at the beginning, did you have to treat patients with lytics, those who were referred, or you could take everyone to the cath lab to the primary PCI? Because I know in China, and even here, some of the guidelines within some institutions says, well, if it's a COVID-19, in order not to contaminate the lab, let's give him, if it's a known or suspected or high suspicious for COVID-19, because you don't have time to do the test, obviously, let's give him lytics therapy and we'll take only those who failed the lytic therapy. Elaine, what was the lytic therapy in your situation?
I mean, there was no lytic therapy. We organized, I have to say, honestly, there was no panic here. There was no panic in this hospital. The scene that you are seeing are from the other two cities in the region, Bergamo and Brescia, that were really hit like a tsunami. In my hospital, we had even patients from other cities. I mean, I have to say that in this tsunami that really hit us, anything was very well organized. So being very well organized and there was no panic, we were able to organize, as I said, the network. And this is why the patients were brought to the hospital that were designed as hub for the ACS network, and they were doing primary PCI. Also because your concept of fibrinolysis in the first 2 hours, we had late presentation. So in general, people were coming after 2 hours because there were different type of delay. The first delay was the call of the patient to the emergency numbers, because as Nicolas was saying, people did not want to come to the hospital because they were afraid of the COVID-19. Then there was the late arrival of the ambulance because ambulances were overwhelmed by COVID-19 emergencies. And then there were still patients going directly to not the hub center that had to be transferred. Having said that, not frequently they were coming in the first 2 hours, so there was no indication for lytics, and there was indication for primary PCI. So anybody came, and if they were not too much late after the 12 hours or 24 hours, and this was really a kind of 18% of the total ST elevation MI coming in our institution, the majority did a primary PCI. So there is not lytic history, I have to say, in the region, unless they were not in the hub center, they were going not in places where you have 24 hours, 7 days, CALAB facilities, and they were doing in the first 2 hours lytics. But in general, it's primary PCI for the reason that I was saying.
That's good to find out. I have another question related to this. We have been seeing reports from China, and we've seen here anecdotal cases of COVID-19 patients with normal coronaries. Yes. And I wonder, still ST elevation, they were rushed to the lab, they were cath, and maybe slow flow, maybe microvascular disease, but no obstructive lesion. How much of those patients, we see those sometimes, you know, but I've noticed that we've seen more than the usual here on our record. These you have seen through this service for the past 2 months.
So we did a collection of all data coming from all the region. So we collected the cases, both ST elevation MI and non-ST elevation MI. For non-ST elevation MI, 81% of the patient COVID-19 positive presenting with non-ST elevation MI, they had no culprit lesion. This is quite striking. Just a minority had a culprit lesion and underwent to PCI. On the ST elevation MI COVID-19 positive, again, more than half of the patient had no culprit lesion. So there are different hypotheses on that. It's called, as you know, as myocardial injury. Is this myocardial injuries, is it a type 2 MI and not a type 1 MI? Is it microinfarction? Is it something related to cytokine release? Honestly, it's a question mark, but it's something we have been observing. As I told you from the series that we did with all the hospital from the Lombardy region.
Do you have experience with those patients? It looks like the disease is lighter in the Netherlands compared to Italy, but am I right, or this is just a different phase or different attitude?
Yeah, I don't know whether the disease is lighter. I think it will. It is the same kind of virus in the Netherlands as in Italy, I would assume, but we don't see it. I haven't seen typical ACS syndromes with normal coronaries in patients who were COVID-19. As a matter of fact, the number of COVID-19 positive patients that went through our cath lab, I can count on two hands. It's marginal. Of course, you do.
You're a tertiary center. Yeah, you are a tertiary center.
Yes, we are the highest. We are the largest. We are the control room, the control center for the pandemic in the Netherlands. We escalated our ICU care by a factor, by threefold. So we get referrals from a lot of the regions in the country. But somehow you do see in the ICU that patients have some mild troponin rise, but we did not see these patients who were coming in for an acute coronary syndrome had a COVID positive and then had normal coronaries. No, we haven't seen that. We just have not seen that.
Let me ask you some controversial issues here in the US that we're struggling. Let's start with hydroxychloroquine with or without azithromycin. Are healthcare providers in your institution taking those drugs prophylactically, or they completely don't believe in that? I mean, what's the approach to take those drugs in the Netherlands?
There is no recommendation. So we don't, I don't take it. I would not want to take it, by the way, because all these drugs, they also have side effects, of course. And if it's not a proven benefit, then I will not take it prophylactically. I do know that my hospital has initiated a prospective study using plasma to treat the COVID-19 patients, and that has been going on in the ICU. They have been prescribing hydrochloroquine, but I think they stopped doing it now because I think the evidence is, I mean, it's not evidence-based medicine, and of course you could make the argument, yes, but if it is of no benefit, it will not harm. But we all know that hydrochloroquine can prolong QT segments and so on and so on. So there are also issues there. So it's not systematic treatment for COVID patients here in at least not in Rotterdam. And there is not like a national recommendation on how to treat these patients.
It's pretty much the same as here. Aleda, wondering if it's different in Italy. You obviously have been seen so many therapies going on in Italy with such a robust number of patients. So if you can comment on the hydroxychloroquine or any other drug or any other therapy that anecdotally you can think that it may make a change.
So regarding the prophylactic use, at the beginning there were some physicians around Italy and in the city taking this prophylactically. That's why there was then a note from the region saying that there is no evidence that prophylactically this can work. Having said that, as far as I know, there will be a study with in the future, in the next future, looking also to prophylactic use of this drug. Then, regarding the use as a therapy, this is given in some regions in Italy to patients that are at home, because, you know, it's all a question of denominator, I think. The denominator here in Italy is higher than Netherlands, and there is no doubt of that. You see the number all the times, and especially in this region and in the northern of Italy. So for some patients being symptomatic with the fever at home, there are some region and some local protocols that for this patient at home, they prescribe the drug, but they are also followed by physician at home. So this is something that in some region and some cities they are doing. Then in this hospital where this huge number of COVID-19 patients, there are a lot of protocols going on with different drugs. There are studies going on. I cannot comment on that because this is something that the hospital is looking at, and I hope that soon we will have results from all the incredible work that they are doing. So let's see in the next future. Maybe
one other thing which is controversial here is about the lockdown. or stay-home policy or sheltering, no matter how you call it. And there are kind of a little bit some protests here in different regions. People wants to go out. I see on the TV that also Italians are going out. So my question to you is, when do you think, or when are you planning to resume elective cases in your hospital? And when do you think you'll resume TAVI in your hospital?
So we don't, so for the lockdown, we have a date, May the 3rd, after, because, you know, this is also a lot of holidays in the meantime. So I think the government for the moment decided that the May the 3rd, there should be something going on. We should not be anymore in lockdown. Then how they still have to decide. Having said that, I have to say that slowly some elective cases are coming, and we didn't cut completely the TAVI. We are doing some TAVI cases. Clearly, we are not in the same range. I mean, in the past, we were doing something like 10 cases a week. Now we are doing a couple, 2 or 3. But let's see. I mean, we have to see what's happening after the stop of the lockdown. If we don't have again the cases going up, and if it's not like that, I think that slowly we will go back to normal elective cases. We had to postpone so many patients that we need to do, honestly, because then elective case after a while, if you turn down the lockdown and they start to walk again, they will have angina. So, I mean, I hope that we will start by middle May. Let's see.
Do you think that the main reason not to return immediately normal because patients are afraid to come to the hospital, or you don't have enough resources in the hospital because you're still flooded with COVID-19 patients? Which one is the more important one? I mean, the more impactful one on the number of cases as you want to extend to more elective cases?
But first of all, our beds, because we were asked by the hospital to give some beds for COVID-19 patients. So that the biggest problem that we are having is the beds. If in those beds there are not COVID-19, but let's say that they had to organize a part of the hospital for COVID-19. So we had also patients from other wards, not COVID-19, coming to our beds. So whenever we will have, again, our normal range of beds, we can go back to elective procedure because it's more a logistic problem of beds.
It's a resources issue.
Resources is not people, but really how to allocate the patients. And now we are seeing less COVID-19 patients. For the first time last week, we had even intensive unit care beds free. So, I mean, when this will be going on, then we can slowly go back to have elective patients.
So Ron,
we really have to work step by step, because that's very important, step by step.
Thank you, Nicholas.
Yeah, so I would like to make a comment on elective cases, because of course there is a difference between an elective TAVI case and an elective PCI case. There is no patient who is going to die for postponing an elective PCI of a mid-RCA if it's in a stable situation. So not talking about ACS, but stable angina. If you do not treat a patient with symptomatic severe aortic stenosis, your 1-year mortality is 25%. And I believe that is unacceptable. As a matter of fact, when this COVID crisis started, I immediately went to the head of cardiology to talk to the administration and make sure that the TAVI program would not be affected, because we don't want our patients to die on the waiting list. And normally we all are aware of the fact that if you have a waiting list for patients with symptomatic severe aortic stenosis, it is around 5%. If this starts to increase to 20%, that is a high price to pay. And I believe that, it's, as policymakers, they have to make decisions, but we will only know a couple of months from now whether those decisions were the good ones. And it's going to be explosive because in several months from now, we will see what the socio-economic impact will be. And the socio-economic impact will be on younger patients, on younger persons. And if you would see that there is an increase in criminality, in suicide or whatever, because people do not, they have no resources anymore. There's no income. Because we took certain drastic decisions to treat all these COVID patients.
I agree with you. Yeah, I agree with you
but
on the aortic stenosis. I agree with you on the other issues which could be impactful, hungry, and not doing any preventive medicine. I mean, there would be an issue. I just wanted to ask you, so on the aortic stenosis, I agree with you completely. I don't think that's elective. What about mitral clip? What about LAA closure? Where would you categorize those?
Yeah, and so in Rotterdam, that's a different story. So we did a couple of mitral clips, but very limited. We did a couple of mitral clips in patients who had recurrent hospitalizations for acute on chronic heart failure with functional MR. Because those patients, their quality of life was really bad and they were like digressing. But in principle, when we would do elective or planned cases in the cath lab that would require general anesthesia and or ICU care, expected ICU care, we would postpone those cases. I think that would not be fair to burden our ICU with stable elective cases. So that is.
You wanted to add something to that?
Yeah, because I think that's very interesting, the webinar, because you're seeing two different countries with different denominators, because I absolutely agree to what Nicholas was saying, but we were in a war. And honestly, in a war, you have to decide and make decision. So if you want to treat older people or you want to treat younger people, because the mean, despite the fact that as anybody knows in the past, because now, unfortunately, I don't think we will have any more. We had one of the oldest population in the Western world in Italy, and you know that this was a disease that really make die so many old people. But in reality, in our intensive unit care, you maybe saw in one publication that was in JAMA from the region, and our intensivist median age was 63. Of COVID-19 patients. So we had to make, I mean, not me, luckily, but they had to make a decision in this war who want you to save, older people with comorbidities undergoing to TAVI, or a 60-year-old person that has a normal life and get a pneumonia or whatever it is from COVID-19 and is in intensive unit care. So unfortunately, that was very unfortunate. We had they had to take decision, and the decision was, as in any war, to fight for younger patients. That's how it is. That's very bad. I don't like peace at all, but we were in a war, and so we had to fight a war. And so there are two different countries with different denominators and experience. And I respect what Nicola said, but they had to take a decision.
And I agree, it's different from territory to territory. And also the number of patients that are in the hospital. Like in our hospital, we have right now 170 patients with COVID. It's a hospital of 850 beds. Okay, I talked to my son who is doing internal medicine, Maimonides in Brooklyn, and their hospital is only COVID-19 patients, and it's more than 700 beds right now. I don't know how is that in Rotterdam. It's probably more on our side, but so I think you cannot make one rule for, that's why all those consensus documents that are coming, I mean, they're a little bit detached from the reality. It may be good for certain people in a certain institution, but you cannot generalize it across all the board to every institution.
Mm-hmm. No, and I think that the discussion has so many layers to it, but I think it's going to be very interesting to see a couple of months from now when we all look back and say, okay, what have we done and where are we now and what are the consequences of those decisions? And I think nobody knows. Nobody knows.
I have two questions to you. One is, do you think that those elective patients in PCI that we don't do them now will ever come back to us, or there will be like a scar on the volume of intervention. As you know, I mean, you talk to major companies, they have 80% reduction in revenues. This is globally or in the US. My concern is that you tell someone you're elective, you don't have to do the procedure now. Maybe you'll say, okay, I'll stay elective for the duration of my life. So how fast do you think we'll resume to things that were before the COVID-19 era in terms of volume procedures that we're doing?
Well, if you ask my opinion,
yes.
I think it depends also on the treating physician, the mentality of the treating physician. I have the impression that a lot of some general cardiologists, they would just say, you know what, we have stabilized you and everything goes well. You know, if the situation deteriorates, let us know, and then we would send you for a PET. I would have a different approach. When I would do a follow-up on my patients, I would offer them a PCI opportunity as soon as possible. Yeah.
Yeah, I agree with you. Maybe last question to you, Nicolas. The European Heart Meeting is planned to be in Amsterdam, in the Netherlands. With the whole social distancing and what's happening right now in the Netherlands and the prevalence of the disease, what should we expect? I mean, you still think, I mean, there is nothing officially announced for maybe reasons for practicality. Should we plan to be there? Should we plan not to be there? Well, what would you sense? I know you're not official spokesman for the ESC, but you're a European and you're a Dutch, so I wonder what is your thoughts?
Well, I'm lucky that I'm not in a position that I need to make official statements on that now. I hope that by the end of summer, we will have found a new normal, and that people will be again have the opportunity to travel. That said, I think that there are some implications of what people are experiencing now. People will think twice, why would I go to a big conference if I can get education online? You will see. So I honestly believe that the ESC meeting will happen. I think it will be a face-to-face meeting, but I also believe that it will be smaller than they anticipated.
We just had experience with ACC on a virtual. It actually was pretty informative. A lot of talks, a lot of late-breaking trials. You can do it at your own time. We're missing the social networking, but it's a different era. Aled, any thoughts when things will become back to normal in Italy? I mean, when would you say the most optimistic Italians in the community of medical community believe that things will come back to normal?
I mean, I think in the summertime, I'm optimistic because in life you have to be optimistic, you know, that's it. So European Society of Cardiology, they still send out the invitation. So theoretically it's going to be, I agree with Nicolas. I think it will be also personal decision what to do. I hope that soon things will be finished here in Italy and be quiet, and that you will come back to our beautiful country in this summer to stay with us. And let's be optimistic.
We have to. So I'd like to thank both of you, Aled and Nicolas, for being optimistic, for being so forthcoming and telling us about your experience. I think it's very important to see how things are evolving in a positive way with reduction of COVID-19 patients, with more therapies. My personal feeling that probably less than a year from now, we'll have a vaccination and they'll take care of most of the concerns. I mean, I'm not sure about the meetings. We'll have to do some differences, but eventually will come, and hopefully we'll be even more robust because from every struggle, we're becoming stronger and stronger. So stay healthy and safe, and I hope to see you whenever it comes, if not online, sometimes in person as well. Thank you very much, guys.
Bye.
Thank you very much. Good to see you, Ron. Good to see you, Aled. Stay well.
Bye. See you soon.
Thank you, Aled.